Welcome. In this session, we will be discussing the remaining portion of examination and diagnostic in neuro-ophthalmology, and we will be discussing B-scan ultrasound, optical coherence tomography, fundus fluorescent angiography, fundus autofluorescence, electrophysiology, perimetry as related to neuro-ophthalmology. Also, we will discuss how to differentiate optic neuropathies from maculopathies, a very important topic. Starting with ultrasonography, we can use B-scan ultrasound for imaging extraocular muscles in thyroid eye disease and for imaging the optic nerve head to differentiate drusen's from optic nerve head edema. We see hyperechogenicity. Ultrasound technology is also used for Doppler imaging of cervical carotid arteries, but more proximal or more distal arteries other than the cervical carotid arteries cannot be imaged with ultrasonography, and this is important in patients with TVL, transient visual loss, which we will be discussing in a separate presentation altogether. So this Doppler imaging can detect stenosis, but they are not accurate, they are not said to be accurate for detecting dissection. Doppler imaging of superior ophthalmic vein can be done to detect reversed flow in the superior ophthalmic vein in carotid cavernous fistula. And we can also image temporal arteries to diagnose giant cell arteritis with ultrasonography. So, the utility of optical coherence tomography in neuro-ophthalmology. In recent years, OCT has gained importance in neuro-ophthalmology in addition to retinal or macular diseases and glaucoma. So, in neuro-ophthalmology, OCT can be used to detect early disease, particularly in toxic optic neuropathies. It can be utilized for prognostication, particularly in optic nerve head edemas, and for following up resolution or progress of the disease, also in case of optic nerve head edemas. Two OCT scans are most relevant in neuro-ophthalmology. One is centered on the disc called peripapillary retinal nerve fiber layer or PRNFL thickness, and the other is ganglion cell to inner plexiform layer thickness centered on fovea. So this is the GCIPL scan and this is the PRNFL scan, and both are important. So this figure shows what we mean by PRNFL thickness and what do we mean by GCIPL thickness. So PRNFL thickness measures the thickness only of the retinal nerve fiber layer, and this is thickest near the optic disc. And GCIPL thickness measures the thickness from the outer margin of the RNFL layer to the outer margin of the inner plexiform layer. So it measures the thickness of the ganglion cell layer GC and the inner plexiform layer. So it includes these two layers, and we see that it is thickest nearest to the fovea, although not in the fovea itself. So this is a very important concept to remember. In certain situations, papillomacular bundle is the primary target, such as in toxic optic neuropathies and hereditary optic neuropathies. So if the papillomacular bundle is affected, the PRNFL thickness will show reduction in the temporal quadrant, whereas the GCIPL thickness will show reduction preferentially in the nasal quadrant. So this is also very important to remember, and these two pictures, this one and this one, should be remembered or should be kept in mind when we discuss the individual diseases. So thinning of PRNFL or GCIPL helps in differentiating optic neuropathies from retinopathies. Serial measurement of PRNFL thickness helps in serial evaluation of optic nerve edema. Unless there is severe long-standing disease, thickness of less than 40 microns, particularly a localized thickness of either the p-RNFL or GC-IPL, indicates segmentation error. So what is segmentation error? Segmentation error is if the OCT images the retina here and is asked to find the macular thickness at this region, it has to identify the anterior extent of the retina and the posterior extent of the retina, and then only it can measure the thickness. So identifying this layer and identifying this layer is called segmentation, and only if segmentation is accurate, the resulting thickness measurement will be accurate, and the segmentation holds for any other layer of the retina. So if we wish to measure thickness between these two, maybe the GC-IPL, so this identification of the layer or the boundary between two layers is called segmentation. Optic nerve edema can cause segmentation errors, usually represented by black rectangular areas in the scan image. Now when we are measuring p-RNFL thickness serially, a test-retest variability between two sequential tests of up to 8 microns is considered not to be significant. Abnormal regional variations in p-RNFL thickness, we know the Isn't rule, in which the inferior quadrant or the inferior sector of the nerve fiber layer is the thickest, followed by superior, followed by nasal, followed by temporal, which follows the thickness of the neuroretinal rim. So the abnormal regional variation in p-RNFL thickness can occur in certain situations, like long or short axial length eyes, abnormal locations of the major blood vessels at ONH, and ocular torsion. So when we are evaluating highly myopic eyes, generally there is an underestimation of ONH size and p-RNFL thickness. In addition, in highly myopic eyes, we find temporal displacement of major retinal vessels and arcuate bundles. So you find the temporal major blood vessels are shifted towards the temporal margin of the disc compared to a normal fundus. As a result, there is an increase in temporal RNFL thickness, but decreasing superior and inferior RNFL thickness. So RNFL thickness increases in this sector and decreases in these two sectors. So in a normal fundus, we expect the RNFL thickness to be higher in these two sectors compared to this, but it may be altered in a highly myopic eye, and this may appear thicker compared to normal, and these may appear thinner compared to normal. Thus, when a patient has already undergone a cataract surgery or a refractive surgery, we must know the axial length to properly assess the p-RNFL thickness. Now we will be discussing the OCT features in individual situations. We will be discussing the individual situations separately when the topic comes in subsequent presentations. What I have done is I have collected the OCT features together so that it becomes a little bit easier to compare. And this section of the presentation is quite monotonous, so please bear with me. So when there is a thickening of the optic nerve head, what we find is the GC-IPL thickness does not increase with increasing edema. So the edema is restricted to the p-RNFL or the retinal nerve fiber layer, and the GC-IPL thickness does not increase with ONH edema. GC-IPL thinning occurs when there is axonal loss subsequent to chronic papilledema. However, a p-RNFL thinning can happen due to either the edema resolving with time or may also be due to an axonal loss. As a result, the p-RNFL thinning cannot differentiate between a resolving edema and a progressing axonal loss. and so the GC-IPL thinning becomes an early indicator of axonal loss. We can also find subretinal hyporeflective space around the optic nerve in a lazy V pattern. So this is the lazy V pattern with the fluid accumulating in the subretinal space. Also not shown here, we can find anterior displacement of Bruch's membrane in papilledema, which is not found in non-arteritic ischemic optic neuropathy, where we may get optic nerval edema in the early stages. With severe ONH edema, as we have discussed, OCT is less helpful because of segmentation errors. What do we find in optic disc drusen? In EDI OCT, EDI is an enhanced depth imaging in SD-OCT, and SS-OCT is a separate method of OCT altogether. It uses a different set of projected light. So they show spheroidal hyporeflective area within the ONH with hyperreflective plaques on the surface. So this is the cap side. Now a hyporeflective area within the optic nerve head can also be due to a blood vessel. However, the blood vessels have shadows or reflections posteriorly, which does not occur with an optic nerve head drusen. Coming to demyelinating disease, first we have multiple sclerosis. In acute optic neuritis, initially ONH edema occurs. So this is not retrobulbar neuritis, we are talking about optic neuritis. So there is an ONH edema initially, and that results in PRNFL thickness increase. And since there is ONH edema, as we have seen in the earlier slide, that there is peripapillary hyporeflective space from subretinal fluid, and this edema resolves by a couple of months. Then there is progressive PRNFL thinning in the temporal sector, and this continues to occur or progress or deteriorate till about 6 months after onset. It has been seen that the GC-IPL thickness correlates better with visual acuity. So the thinner the GC-IPL, the less the visual acuity, and PRNFL thickness has been shown to also inversely correlate with neurologic disability. Now in an MS without optic neuritis, it has been shown that the PRNFL thinning correlates with lesion volume in the brain. Coming to another form of demyelinating disease, neuromyelitis optica, which is more severe, rarer but more severe than multiple sclerosis, the PRNFL thickness loss is more severe and is more diffuse. In MS we find PRNFL loss mostly in the temporal sector, while in NMO we find PRNFL thinning mostly in the superior and inferior sectors. Now in contrast to multiple sclerosis, in neuromyelitis optica we find further PRNFL loss with subsequent episodes of optic neuritis. And in unilateral cases, the PRNFL thickness difference of more than 15 microns between the affected and non-affected eye is found more frequently in neuromyelitis optica compared to multiple sclerosis. So the decrease in PRNFL thickness can be more asymmetrical in NMO. Coming to LHON, a hereditary form of optic neuropathy and an important topic in neuro-ophthalmology. So in LHON, the RNFL in the unaffected carrier shows a thickening of the temporal sector compared to controls. Now in the typical form in young adults, in contrast to the childhood onset acute form, after the onset of the acute phase, the temporal sector shows no difference from controls, implying that it has already started to thin after thickening in the pre-symptomatic phase. Then in the first 3 months after symptom onset, the inferior sector, and in the next 3 months the superior and the nasal sectors thicken. followed by their subsequent sequential thinning. And after 6 months, all the sectors are found to be thin. In childhood onset acute form, all sectors show thinning. And in the slowly progressive and the subclinical form, temporal sector thinning predominates, and the remaining sectors, inferior, superior and nasal, may be spared. So what happens to the GCIPL in LHON? The GCIPL thinning occurs before RNFL thinning. So here also the GCIPL does not thicken in the early stage, and GCIPL may be able to predict conversion from a pre-symptomatic to a symptomatic phase, because it has been found that 6 weeks before clinical onset, thinning of nasal sector of the GCIPL in the inner ring occurs, followed by inner, inferior and outer nasal sectors before symptom onset. 6 months after the onset, there is diffuse loss. And when the disc area is analyzed in LHON, a significantly smaller disc is found in those with acute onset disease compared to normals and those with slowly progressive disease. So a small disc may predispose to the acute onset form of LHON. Then we have another hereditary form of optic neuropathy called ADOA, or autosomal dominant optic atrophy. So here the PRNFL thinning occurs predominantly in the temporal as well as the inferior sectors, but progression rate of thinning with age is similar to normals. GCIPL is diffusely thin and occurs earlier than PRNFL. Both in LHON and in ADOA, GCIPL thins earlier than PRNFL, and the disc area is also found to be small. In toxic or nutritional deficiency optic neuropathy, OCT is very helpful in early diagnosis and may help us to determine whether we need to stop the toxic drug or treat a nutritional deficiency. So this is an important application of OCT in neuro-ophthalmology. Papillomacular bundle is the most susceptible, like hereditary optic neuropathies, and this is reflected in the temporal PRNFL sector and nasal GCIPL sector, which we have already discussed. In early stage, there is thickening of PRNFL layer. So there is initially a thickening followed by thinning of the PRNFL and GCIPL. So the GCIPL does not thicken. In late stages, there is diffuse thinning of both PRNFL and GCIPL. Toxic optic neuropathies can happen with alcohol, isoniazid, ethambutol, amiodarone, infliximab, and nutritional deficiency optic neuropathy can happen with deficiency of vitamin. Now coming to compressive optic neuropathy, again there is PRNFL thinning in the nasal and temporal quadrants. So here the nasal quadrant is also affected and is more than in glaucomatous optic neuropathy. Compressive optic neuropathy and glaucomatous optic neuropathy can be difficult to differentiate because both are slowly progressive disease, and compressive optic neuropathy can present with cupping, significant cupping compared to pallor of the neuroretinal rim. Normal pretreatment PRNFL thickness is a good prognostic indicator in compressive optic neuropathy also. Coming to chiasmal compression, diffuse PRNFL thickening preferentially in nasal and temporal quadrants here also, and binasal thinning of GCIPL has been observed in chiasmal compression. If PRNFL thickness is more than 75 microns, prognosis for visual recovery has been found to be good. Following chiasmal decompression, both PRNFL and GCIPL thickness continues to decrease for another about 3 months before recovering in the next 6 months. In retrogeniculate lesion, we may find GCIPL thinning. This is because of a transsynaptic retrograde degeneration which can happen in occipital infarction also. And in retrogeniculate lesion, the GC-IPL thinning has been found to better correlate with visual field defect than PRNFL. In occipital infarction, the PRNFL thinning starts to occur within 4 months. Why transsynaptic? Because there is a synapse in the lateral geniculate nucleus between the retrogeniculate and the plegeniculate section of the visual pathway. Superior, inferior and temporal sectors are affected in the ipsilateral eye, and superior, inferior and nasal sectors are affected in the contralateral eye. Retina contains dopaminergic amacrine cells, and being dopaminergic, these cells may be affected in Parkinson's disease, and it has been found that the GC-IPL thickness correlates inversely with the disease severity and duration. PRNFL thinning occurs characteristically in the temporal sector, and eye contralateral to the side of the body more affected with the Parkinson's symptom shows more severe changes in OCT. Alzheimer's disease and a milder form of dementia called MCI or mild cognitive impairment both show PRNFL thinning. In AD or Alzheimer's disease, PRNFL thinning is maximum in the superior quadrant. It has been found that the GC-IPL thinning is correlated with disease severity and duration, and has been found to be more sensitive than PRNFL in distinguishing AD from normals. Friedreich's ataxia, a form of hereditary cerebral disease, also shows diffuse loss of PRNFL and GC-IPL without selectivity for temporal sectors. OCTA can also show reduced vessel density within optic disc and in PRNFL in various optic neuropathies. Now, after OCT, we will discuss the importance of fluorescent angiography in neuro-ophthalmology. So, in giant cell arteritis, there is delayed or absent choroidal filling. So, here we find delayed or absent choroidal filling, whereas the retinal filling has already started and there is no obstruction, and the choroidal flush, as it is called, is interrupted in several areas. In true ONH edema, we find leakage, whereas in LHON and ODD, although there may be disc swelling or apparent disc swelling, there is no leakage of dye in fundus fluorescent angiography. In inflammatory optic neuropathies, FFA can show peripheral vasculitis with occlusion and leakage. Coming to fundus autofluorescence, fundus autofluorescence helps us to detect superficial ODD or optic disc drusen. Optic disc drusens are said to be autofluorescent. They do not require fluorescein to fluoresce. Fundus autofluorescence also helps us to detect subtle maculopathies, which may be mistaken as an optic neuropathy. So these subtle maculopathies include AZUR, acute zonal occult outer retinopathy, AMN, acute macular neuroretinopathy, and MUDS, that is multiple evanescent white dot syndrome, which we will be discussing in the presentations on posterior segment and uveitis. Then we have electrophysiology. The role of electrophysiology is limited in neuro-ophthalmology. So coming to role of visual evoked potential in neuro-ophthalmology, consistently abnormal response in flash VEP indicates grossly abnormal afferent visual pathway. So this can be due to both a extensive retinal disorder or an optic neuropathy or a disorder in the visual pathway. Only when we have a normal response in the ERG with an abnormal response in VEP, only then we can locate that the lesion is behind the retina in the visual pathway. And if the pattern VEP shows a normal response, that indicates an intact visual pathway. VEP is important in two scenarios in neuro-ophthalmology: assessing visual pathways in inarticulate patient and confirming intact visual pathway in non-organic vision loss, which may be psychological or in patients who are malingering. Electroretinography shows early abnormalities in diffuse retinal disorders, which may be subtle clinically, like cancer-associated retinopathy, melanoma-associated retinopathy, and some dystrophies. And these can be mistaken for optic neuropathies because they are subtle in ophthalmoscopic features in the initial phases. Multifocal ERG differentiates focal macular diseases from optic neuropathy. Optic neuropathy does not show any abnormality in multifocal ERG. So analysis of visual field defects help us to localize lesions in the afferent visual pathway. This is very important. We have already discussed in a previous session that post-chiasmal field defects respect vertical meridian, whereas optic nerve diseases such as glaucoma and acute ischemic optic neuropathy have field defects which may respect horizontal meridian. Since almost 80% of the visual cortex represents the central visual field, we can only evaluate the central 24 to 30 degrees of the visual field to detect most of the neuro-ophthalmic visual field defects. The only thing we are going to miss is the temporal crescent, which is supplied by the contralateral anterior visual cortex. And if there is a temporal crescentic loss from lesions of that contralateral anterior visual cortex, we are going to miss that in a 24 to 30 degree visual field analysis. Gross optic neuropathies show significant abnormality in the total deviation plot, with no or minimal abnormality in the pattern deviation plot, which happens in glaucoma. The pattern deviation plot is important to detect field defects or scotomas of glaucoma. Now coming to the last section of this session, how to differentiate optic neuropathy from maculopathy, and this is a important topic. So common etiologies may have subtle ophthalmoscopic findings, as we have discussed, which are difficult to detect and differentiate. Optic neuropathies present with generalized dimness of vision, and the patient may perceive black spots or curtains across the visual field, whereas maculopathies present with metamorphopsia in the central visual field. Micropsia is more common than macropsia when fluid accumulates in the retina and the photoreceptors are more distant from each other. And maculopathies do not show a generalized dimness of the entire field. Patient complains that only the central portion of the visual field is affected. Optic neuropathies show RAPD. Maculopathies, being localized, usually do not show RAPD. In optic neuropathies, abnormalities on color vision testing and brightness sensitivity testing are more severe than the decline in visual acuity, whereas in maculopathies, color vision and brightness sensitivity functions are affected to a similar extent as compared to visual acuity. And brightness sensitivity may actually be increased in certain maculopathies. Optic neuropathies may have varied patterns of visual field defects depending on the etiology, whereas maculopathies almost always show a central scotoma because the macula involves only the central portion of the fundus. On contrast sensitivity testing with sine wave gratings, subtle optic neuropathies show defect in middle to high frequencies of the sine wave gratings, whereas subtle maculopathies show defect only in the highest frequencies. Optic neuropathies have normal photostress recovery time, which is significantly prolonged in maculopathies. OCT, FFA, autofluorescence and MFERG can help in detecting maculopathies, as we have discussed in the previous slides, and tests which do not help in distinguishing between optic neuropathy and maculopathy are visual evoked potential, which we have discussed in a previous slide, and potential acuity meter, which helps in differentiating media opacities like cataract from maculopathy and optic neuropathy. Thank you for listening.